Hello everyone, this is Dr. A. We're going to go over diseases of the bone, joints, and skeletal muscles. This is actually chapter 27 and 28 of Larson's Clinical Chemistry. And let's just quickly review the normal anatomy and physiology of bones. So bones are metabolically active. They're not dead like we think of, a dead skeleton and just the bones aren't alive. But yeah, the bones are actually tissue that's alive. They're being, bone matter's being regenerated, replaced all the time throughout your life. And so that is important. And you have to have the right nutrition, the right amount of minerals for this to happen optimally. So there are several types of bones. There's the long bones, short bones, and flat bones. And there's irregular bones in there too. The long bones are what you would think of like it portrayed here to be the bones of your arms and your legs, and they're long, right? And fingers are long bones and stuff. Short bones are going to be more like the bones in your wrist, for example. Those are short bones, the little square bones, right? Flat bones would be bones of your skull. So your ribs are flat, your shoulder blade is flat. So having any regular bones like your vertebrae are irregular. The bone is composed of a periosteum, which is the wrapping around the bone and from which bone can be regenerated. And then you'll see spongy bone and compact bone. So the compact bone is usually on the outside and makes it strong, and then the spongy bone makes it lightweight. And then there's also the bone cavity, and so there's red marrow and yellow marrow. Yellow marrow tends to be usually in the middle, in the long cavity in the diaphysis here of the bone, and then the spongy bone tends to hold the red marrow. The red marrow will be where the bone building cells and the blood building cells are located. The bone building cells are in the periosteum. The cavity is also lined with endosteum. And in a long bone, the rounded ends at both ends are the epiphysis. Then we got the metaphysis, which is that transition, and then the long part, the shaft of the bone, is the diaphysis. Again, the periosteum wraps around it, and the periosteum actually extends and becomes the ligaments and tendons that anchor bone to bone and muscle to bone. So we get the medullary cavity with the yellow bone marrow, spongy bone with the red bone marrow, the endosteum lining the cavity, and then there is a blood supply in the bone. So the bone again is active and is connected to the blood supply. So that's a good overview right there. So let's start with the diseases. So the first one is Osteogenesis Imperfecta. It is also known as brittle bone disease, and a basic defect, it's a genetic defect here, is either a quantitative or qualitative reduction in type 1 collagen. So bones are made of collagen, in which crystals are deposited of calcium and phosphorus, and it's actually hydroxyapatite crystals that make it strong. Some of the characteristics of patients with osteogenesis imperfecta are that they have a blue sclera, so the white of their eyes actually has a blue tone to it, again because of that lack in type 1 collagen, which type 1 collagen is found other places in the body, not just in the bone. They have defective middle ear bones, so they have problems hearing, right? Abnormal tooth development, again because type 1 collagen is involved in teeth and formation and bone formation around the teeth, and then bone deformities. So you usually, when you analyze it, you can see quantitative or qualitative, again, reduction in type 1 collagen. And lab studies usually tend to be useful in ruling out other abnormalities and then getting to this diagnosis based on everything that presents. So the next one is Paget's disease. In Paget's, there's excessive bone resorption. And so again, bone is alive, and so there's always this resorption and rebuilding of bone. So bone being basically taken down and built back up, taken down, built back up. And so there's excessive resorption, excessive breaking down, and that prompts newborn formation. But the newborn bone formation is not laid the way it's supposed to, and so it's producing a disordered pattern, which then makes it weaker, and it's mechanically weaker. So this can be due to a combination of genetic and environmental factors. Environmental factors could be related to nutrition, but also different chemical exposures and stuff. You see high alkaline phosphatase levels, but this is obviously bone-specific alkaline phosphatase levels. So everything else that's liver-related should be normal. If you need a distinction on where the alkaline phosphatase is coming from, the easiest test to do is probably going to be the GGT. It's the most widely available. If the GGT is normal, then you know the alkaline phosphatase is going to be from bone origin and not liver origin. And then, of course, radiology studies are necessary also for diagnosis. Rickets is a disease of children and adolescents, so as they are growing. And the most common cause of rickets is vitamin D deficiency. And these kids or adolescents tend to have like bowed legs because the bone's a little too soft. Less common cause is going to be a deficiency of calcium or phosphorus, although we usually can get enough calcium or phosphorus. So the thing is, what you have to understand is you have to have vitamin D present to be able to absorb calcium from the diet. And so there could be adequate amounts of calcium supplied, but if there's not enough vitamin D, then the calcium is not going to be properly absorbed. So patients with rickets have skeletal deformities, especially in their limbs, and have short stature. They can't grow because they can't get enough calcium into their bones to be able to lengthen their bones. The lab results will show the calcium and phosphorus are low because they're not absorbing it, again, or not getting enough of it in. The alkaline phosphatase is high, and this is going to be bone origin alkaline phosphatase again. And parathyroid hormone is going to be high because the calcium is low, right? And the 25-hydroxyvitamin D and 1,2,5-dihydroxyvitamin D, which is the active form of vitamin D, is going to be low. So you want to check all of these things. You want to check the calcium, the phosphorus, the vitamin D levels, the alkaline phosphatase, and the parathyroid hormone. So let's talk a little bit about the analytical procedures. So we're going to go with calcium first. It is the most prevalent inorganic ion in the body. 99% of calcium is stored in the skeleton, and so the other 1% is floating around in your blood and is also in your muscles. So there are three forms that exist in the blood floating around. There's free calcium, also known as ionized calcium, and that's about half of the calcium in your blood. Then there's some that's bound to plasma protein, which is almost the other half. It's about 40%. And then the rest is bound to diffusible anions like phosphates, bicarbonates, etc. The role of calcium in the body, so extracellular calcium, so this is the calcium that's floating around in the blood, is needed for bone mineralization, blood coagulation, and other functions. And then, of course, it also needs to resupply the cells with calcium. And so inside the cells, intracellular calcium has key roles in muscle contractions inside the muscle cells, including heart muscle, and especially heart muscle, hormone secretion, glycogen metabolism, and cell division. So calcium is important all over the body, right? It got so many different roles in there. So it's more than just about bones. So do you remember, or do you know which hormone raises your blood calcium levels? So if your blood calcium levels are low, which one of these two will kick in to raise it up? So I've already mentioned it, but let's see what you remember. Okay, so here's the answer. So if you have low blood calcium levels, then your parathyroids are going to sense that. They have direct little sensors there for the calcium level in your blood, and it will cause your parathyroid glands to release parathyroid hormone. Parathyroid hormone goes to the bone and starts breaking the bone down to release calcium levels in the blood and to normalize calcium levels. So it will do other things though. Also, it will cause the kidneys to conserve more calcium. It will cause the intestines to absorb more calcium, but you have to have vitamin D for that to happen. Okay. So if you have high levels of calcium, then calcitonin is secreted from the thyroid. So these are the parafollicular cells of the thyroid, not the same cells that make thyroid hormones, but they are located in the thyroid. So they release calcitonin, and then calcitonin is going to put the calcium, the high level of calcium that's in the blood, is going to go and put it into the bone. Okay, and so that's what it does with excess calcium it stores. Because where do we store calcium in our blood? We store it in our bones. So there you go. So basically, calcitonin is your calcium storage hormone. All right, moving on from that. So continuing with our lab procedure for calcium, we had a little side step there on explaining what was going on here. So calcium metabolism and hormones. So let's tie it all together. 1,2,5-dihydroxyvitamin D, which is the active metabolite of vitamin D, and parathyroid hormone together regulate calcium. So in bones, 1,2,5-dihydroxyvitamin D stimulates the osteoclasts to mobilize bone calcium, so to break bone down to release calcium into the blood. Then the bone resorption is this process of transferring calcium from bone fluid to blood. So it is a breaking down of bone. Then parathyroid hormone acts on the bones, but also on the kidneys. And in the kidneys, what it does is it increases the reabsorption of tubular calcium. So it keeps it from leaving your body in urine and pulls it back from the urine, puts it back into blood. It will also enhance the hydroxylation of 25-hydroxyvitamin D, which was activated in the liver, and to become the fully active 1,2,5-dihydroxyvitamin D. And then it will go in turn, that active 1,2,5-hydroxyvitamin D will go into your intestines to help absorb more calcium from what's in your food and diet that you've absorbed or you've taken in. So again, how vitamin D works in here in regards to calcium is, so this can be the vitamin D that's created from the UV radiation of cholesterol in your skin. So basically, in your skin, it takes cholesterol and turns it into vitamin D. Or you can take vitamin D3 supplements if that's possible, if that's something that you need. I know this is something that I have to do. And if you're inside a lot, that could be something that you need in our day and age. It seems like everybody's got indoor jobs. We don't spend enough time outside getting enough sunshine. So the vitamin D in supplements are food, although there's not that much vitamin D, maybe some of the fortified milks and stuff, but so taking it in via supplementation or a little bit in food or via sunlight gets into your blood. Vitamin D gets in your blood, and it goes to the liver, and the liver makes it into 25-hydroxyvitamin D. And then that form then can go to the kidneys, and the kidneys can then activate it in 1,2,5-dihydroxyvitamin D, which then has the job of, along with parathyroid hormone, cause the bone to let go of calcium, causes the intestine to absorb more calcium, and causes the calcium to be reabsorbed in the kidneys. So parathyroid hormone is involved in the bone and kidney mechanisms, and vitamin D is involved in the intestine calcium reabsorption. Sorry. So there you go. That's all the relationship between vitamin D, calcium, and parathyroid hormone. So, question. So if you have vitamin D deficiency, would you expect the patient to have hypocalcemia or hypercalcemia? Which one would it be? If not enough vitamin D, which one do we have? If you're not sure, just go back and look at it again. So, or let me give you the answer here in just a second. So the clinical significance of calcium is hypocalcemia, or low levels of calcium in the blood, could be due to vitamin D deficiency, or the results of neck surgery, which could temporarily disrupt the parathyroid glands and cause not enough parathyroid hormone to be secreted. Could also be due to magnesium deficiency. So that's another mineral that can lack. It's just simply not as prevalent in a food as it once was. And magnesium can be used up, especially if patients are under any kind of chronic disease or stress. And so that either the neck surgery or the magnesium deficiency could inhibit the secretion of parathyroid hormone, and then that would lead to hypocalcemia. So vitamin D deficiency and not enough parathyroid hormone, those are two causes of not having enough calcium in the blood. And causes of hypercalcemia, so too much calcium in the blood, could be increased intestinal absorption, increased renal retention, increased skeletal resorption, so the more of it's being released from the skeleton, or a combination of all three of those. So the procedures for calcium, so important points for calcium measurement are to never use EDTA, which is purple top, citrates, which is usually the blue top, or oxalates, which is the gray top, as anticoagulants, because they all bind calcium as part of their anticoagulant effects. And of course, that would falsify the readings. So your measurements of ionized calcium require specimens. So that was falsify your readings. And also, you need to consider that the measurements of ionized calcium will require a specimen that has not been exposed to air. So that tube needs to be stayed closed until it's time to analyze it. The next lab procedure is phosphorus. So 85% of phosphorus is found in the bones. And in the bones, it provides mineral strength to the bones as it combines with calcium. It is also an integral component of nucleic acids, so your DNA and RNA. It serves as a buffer in bones, serum, and urine, so again, part of the acid-base buffer system. It is regulated by renal excretion and reabsorption, so the kidneys maintain adequate phosphate levels in the blood. And parathyroid hormone, when it's released, will increase phosphate excretion and in exchange for calcium reabsorption. So in an effort to reabsorb more calcium, it will dump more phosphorus, is what happens. And so vitamin D will increase absorption in the intestines and reabsorption in the kidneys if vitamin D is present. Phosphorus does usually have an inverse relationship with calcium, meaning if one goes up, the other one goes down. So the clinical significance of phosphorus, hypophosphatemia, or low phosphate levels in the blood, is usually caused by an increased excretion due to hyperparathyroidism. Again, because the parathyroid hormone will help you retain calcium and dump phosphorus. So low phosphorus, hyperparathyroidism makes sense. And decreased excretion is going to be the most common cause of hyperphosphatemia, so levels that are too high, and that would be mostly due to renal failure. So the kidneys are failing before they can excrete properly, so phosphorus is staying behind in the blood. The lab procedures is usually an ammonium molybdate method on unhemolyzed serum. All right, so parathyroid secretion would stimulate which one of these? Calcium and phosphorus absorption, calcium and phosphorus excretion, calcium absorption, phosphorus excretion, and calcium excretion and phosphorus absorption. So let's make it more specific and say, what does it do on the kidneys, at a level of the kidneys? So if you're not sure, go back and rewind, but I want you to think through on this one. All right, and then the next mineral we're going to look at is going to be magnesium. So most of the magnesium in your body is found in your bones, and hormones are not required for you to absorb magnesium because magnesium is actually really important to your body. The kidneys help maintain magnesium balance by, reclaiming it or getting rid of it if needed be. And again, magnesium is a cofactor in more than 350 different enzymatic reactions. It can be used up and depleted again with chronic diseases and stress, and we just don't get enough of it in our diet. So magnesium is something definitely worth considering when one is looking for good health and good balance. So hypomagnesemia, so not enough magnesium in the blood, is common. It is seen definitely if you have nausea, vomiting, diarrhea, in ICU stays, patients that have diabetes, and we know there's a lot of patients with diabetes. Having too much magnesium is rare, especially too much in the blood. That's really, really rare. On lab procedures, mostly is going to be colorimetric assays for magnesium. They use chelating agents to prevent the interference from calcium. It's usually some kind of color reaction where the color is proportional to the magnesium concentration. Right. Which of these minerals do you know can be used to delay preterm labor? This is an interesting one. So I'm going to go ahead and give you the answer because I haven't mentioned it there. I probably should have mentioned it earlier when I was on the slide, but magnesium. So this is the only reason you would see an elevated magnesium on a patient. So one first clue is those patients come from the labor and delivery floor, and two, they usually are having some kind of preterm labor that needs to be stopped. Magnesium is a relaxant, so you need enough magnesium, for example, to be able to go to sleep, for your muscles to also not cramp up, for your muscles to be able to relax and stuff. And so we basically give patients an overdose of magnesium, kind of not overdose to kill you, although that can possibly happen too, but we give them a good hefty dose, and so their blood levels of magnesium can be easily 3 to 4 times that of normal patients, and it's done on purpose to relax those uterine muscles to try to stop labor. So anyway, so magnesium is the one that can be given to delay preterm labor. So moving on to the joints. The joints are located where two bones meet. There are several types of joints. We have fibrous joints, cartilaginous joints, and synovial joints. So the fibrous joints are where things need to be stable. So an example here in this image are going to be your cranial sutures. They're usually immovable. You need it to be strong. They also are what like anchors your teeth to your bones and stuff. So you want stability in those joints, right? Your cartilaginous joints allow slight movements, more than what would be in fibrous joints, but much less than what would be in synovial joints. So your intervertebral joints, it is an example of a cartilaginous joints. The pubic symphysis, there is another example. So they are slightly movable, right? And then your synovial ones are the ones that allow you to move around. They're shoulder joint, hip joint that are like ball and socket joints, your hinge joints from your elbow, you get a lot of your finger joints and stuff. Those are all going to be synovial joints, and there's usually some form of synovial fluid in there that allows for smooth movements. All right, diseases that affect the joints are osteoarthritis. So osteoarthritis, usually from a mechanical wear and tear of the weight-bearing joints. So it commonly affects the knees, could affect the hips also. And it's where, the cartilage just get worn down. Usually there's some kind of chronic inflammation that breaks it down also. But it's due, again, it can be, obesity can be a cause. It can also be due to a previous injury, maybe during a sport that the person played as a young person, and over time there's just this wear and tear that happens. The cartilage is pretty much gone and ends up being like bone on bone and grinding and stuff, and it's really painful. We diagnose this with radiology studies. There's no really specific lab test for osteoarthritis. So again, if there's an old injury present or the patient's obese and stuff, it's very possible that the arthritis that they might be suffering from is going to be osteoarthritis. Okay, in contrast to that, rheumatoid arthritis is a chronic systemic autoimmune disease. There is growth into the synovium and the joint cartilage, and there's then also destructive enzymes that dissolve the cartilage. There's also loss of cartilage. And there's especially these finger deformities that start forming as the rheumatoid arthritis gets worse and worse. So it is more prevalent, especially in the hands, but other joints. And this one, there are some lab tests. Obviously, x-rays are definitely going to help diagnose that, but as far as the lab tests are concerned, we can do a SED-rate over in hematology, the CRP, C-reactive protein, which is a marker of inflammation, anti-rheumatoid factor, which again would be positive if you have rheumatoid arthritis, and then the anti-CCP, which is one of the components in the joints. And so again, these two make it, of course, tie it back to it being an autoimmune disease along with that increase in inflammation. Then we have ankylosing spondylitis. It is another chronic systemic inflammatory condition. It affects the sacroiliac joints, so the joints of the hip, right, and the actual skeleton, meaning the arms and legs, right, and I'm sorry, that's the appendicular skeleton. I'm so sorry. Who knows, right? Axial skeleton, sorry, is your spinal cord, and in which the joints ossify. Obviously, this is what's being shown here. Should pay attention, right? So in a healthy spine, you have your vertebrae that are, the body of the vertebrae are linked to each other through a cartilaginous disc here. And with ankylosing spondylitis, this inflammation is right there at the cartilage, and then the cartilage slowly disappears and the bones fuse, and that makes the spine look like bamboo, and then of course limits mobility. Obviously, symptoms can improve with activity. Activity can help really clear inflammation. And a diagnosis of ankylosing spondylitis is supported by detection of the HLA-B27 antigen, which then makes me think this has got to be also autoimmune related in some form or another because of the HLA part. Next is gout. So in gout, we have the accumulation of monosodium urate monohydrate crystals in the joints. These crystals are long and thin with pointed ends, look like little, really sharp toothpicks in there. And so these are due to an overproduction of uric acid. And they tend to settle mostly in the big toe joint, but they can settle other places. And they are diagnosed with a synovial fluid aspirate of the joint that is inflamed. And obviously in that synovial fluid aspirate, you would see these monosodium urate crystals. This little exercise, I'm going to skip on through that for my class. So last little section is going to be about the muscles. So a quick review of the normal anatomy and physiology of muscles. So muscles are bundles of contractible fibers that are connected to motor nerves. So a muscle fiber is actually one skeletal muscle cell. So they're the biggest cells in your body. They're, the cells have multiple nuclei, they have bunches of mitochondria, they fill with the myofibrils, and the myofibrils are what actually contract and relax the muscles. They have a blood supply here with capillaries, and each muscle fiber is connected to a motor neuron through the neuromuscular junction, and the signal from the motor neuron causes then the contraction of that one specific muscle fiber. So, generally speaking, skeletal muscle cells and their motor nerves cannot regenerate. Now, usually you have a set number of muscle fiber cells in your body. They can repair, so I don't want you to think they can't repair themselves, but if the damage is extensive and beyond repair, then it's very possible then that it would not repair and just turn to scar tissue. So the nerves, when they fire with an impulse, it travels down and reaches the end of this nerve, and it's going to cause the impulse is going to cause the synaptical vesicles to release the neurotransmitters, which are acetylcholine mostly, and those cross over, and then they bind on a receptor on the muscle end of the synapse here. And then that causes a cascade of change inside of the muscle fiber itself, which causes a contraction of the muscle fiber. And so the signals from the at the neuromuscular junction from the motor axon, the axon of the motor nerve causes the contraction of the muscle fiber. And So you can get neurogenic atrophy, which means that the muscle fibers will just lose basically myofibrils, and they'll get smaller, they'll atrophy, right? And that's usually from lack of use or from lack of impulses coming through to it for it to contract. This can be especially seen in patients that have limited mobility, and maybe they're wheelchair bound or they're bed bound and they're just not using their muscles. Those muscles will just atrophy from lack of use. All right, let's look at a case, because we always got to look at a case. So Devin is 26 and works in a welding shop. A large piece of metal falls on his leg and crushes the bottom half. He's taken to the ER. The attending physicians are going to order some lab tests. Now, I'm sure they'll order like more than this, but the relevant results that come across are that his CK is 1844, so anything above like 200 is high. Sodium is 121, this is way too low. Potassium is 5, this is high, right on the high end. Chloride is 89, that's low, and total CO2 in the blood is 32, which corresponds to the bicarb, that's a little bit high. He also is producing really dark colored urine. So what do you think is going on with him? So we're going to look at, we give you some possibilities. You're going to decide, and we're going to look at all of each one of those, and then you'll see what makes sense. So your guesses, you can take a guess from Duchene Muscular Dystrophy, myasthenia gravis, and rhabdomyolysis. So if you know anything about any of those, you can probably rule 2 of them out pretty easily. Okay, so let's start with the Duchene Muscular Dystrophy. So this is an inherited muscle wasting disease. Okay, so with it being inherited, you should be able to rule that one out from in case, because our case was due to an injury, not something that was inherited. In Duchenne muscular dystrophy and other muscular dystrophies, you see a progressive muscle weakness that develops. Duchenne is the most common and most severe of all the muscular dystrophies. The individual with the gene for that specific disease do not produce a molecule called dystrophin. And so basically what dystrophin does is when muscles contract, it stabilizes them. So when they contract and relax, this protein stabilizes the muscle so it doesn't get injured. So the muscle fibers, each muscle fiber stabilizes it so the muscle fiber doesn't get injured. And so these patients don't produce that. And so without it, what happens is over time the muscles atrophy and die. I'm sure they get injured. And a part of it, and they just don't regenerate properly and stuff. And so, and it's genetic. So, CK is the most useful enzyme of the lab test because it is specific for muscle. The CK levels are quite high in this disease, but do not necessarily correlate with the severity of the disease. Of course, you have to think about it too. Over time, as muscle degenerates, then there's less and less muscle to produce CK. So, can always relate that number to the severity of the disease. Next is going to be the Becker Muscular Dystrophy. It's a milder form of muscular dystrophy. The mutation is in the same gene that causes Duchenne muscular dystrophy, but the symptoms are displayed later in life. In the lab test, it's possible to do a dystrophin gene deletion analysis and a muscle biopsy. The clinical lab tests are going to be the CK, AST, and ALT with a CK that's extremely elevated. It's 5 to 100 times normal, and elevated AST and ALT again from that destruction of the muscle. Now, next we have rhabdomyolysis. So this is the rapid destruction of skeletal muscle cells, which often results from the type of muscle injury. So this actually applies to our case. So the case that was presented was a case of rhabdomyolysis because of a crush injury. So this can be due to trauma. Crush injury can be due to cold injury, but there's so many different causes for rhabdo that it would be a really long list to list all of them. Just know that a massive muscle injury can definitely cause it. So the problem is, with massive injury or massive lysing of the muscle fiber cells is the myoglobin that's normally contained in the muscle fibers get quickly released into the bloodstream. And that is actually really dangerous to the kidneys. It can actually cause renal failure. So the symptoms of rhabdomyolysis are going to be muscle weakness, muscle pain, and a really dark urine. And I'm sure our patient was in pain because they were in an accident there, but they also had really dark urine. The lab test, so CK, is going to be used to monitor treatment. The CK levels can be greater than 100,000, depending on the extent of the injury, but of course you have this rapid lysing of all this muscle. So not only is myoglobin released, but CK, of course, is going to be released too. Labs could have a limit on how high dilution they can perform. And so it's possible that the top CK level characterized are going to be greater than 80,000, although most physicians do want it to be quantitated to a final number, meaning that the tech might have to do some manual dilutions to get it to diluted enough to get a reading to get an actual number as to how high the CK is. Myasthenia gravis, so that was your third option. This is an autoimmune disease. So again, not something that would happen all of a sudden from an injury. So in myasthenia gravis, the antibodies are made to acetylcholine nicotinic postsynaptic receptors. So we were talking in your muscle anatomy how the neuron sends a signal to, and it reaches the synapse to the muscle. It causes a release of acetylcholine as a neurotransmitter. It releases from the nerve synaptic vesicles and crosses the synapse and is supposed to bind on the acetylcholine receptors on the muscle side of the synapse. And if that doesn't happen, or if there's a problem again between the two neurons that connect, and so the acetylcholine cannot transmit that motor neuron signal, then the brain impulses cannot reach the muscle, and so the muscle does not get the signal to contract from the brain. And so that, because the muscle is not getting a signal to contract, it's not being used. Therefore, there will be wasting of the muscle, and that muscle weakness will be progressive as more and more of the receptors get tagged with the antibodies and destroyed. So the lab tests that we do for myasthenia gravis are going to be the anti-acetylcholine receptor antibody, which is the most commonly used. But you can also do an anti-striated muscle antibody test, an anti-MuSK muscle-specific kinase antibody test, and an anti-striational antibody test. So these are all tests that can be done to detect myasthenia gravis. That is my last slide. So that was an overview of everything disease, bone, joints, and muscles. I thank you very much for your attention. If you have any questions, please leave them in comments.